You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Tammy Glover, Nurse Manager of Home Infusion at Penn Medicine in Philadelphia, and member of the Bucks Montgomery County's ONS chapter, to discuss best practices for home infusion and how oncology nurses can implement programs at their institution. Thanks for joining me today, Tammy.
Thank you for having me, Stephanie.
So to start us off on our talk today, can you walk us through the differences between administering infusions in the home versus in a clinic?
Certainly, yes. Administering infusions in the home versus the clinic is very multifocal. The obvious idea of having it in the clinic is a direct support in a controlled environment. We know what's there and what we have. But the downside is most clinics are open only Monday through Friday during daytime hours. And a lot of patients, especially those on maintenance medications like Remicades, work full time, and the hours don't work for them without taking vacation time. So giving them their medications in the home allows for them to pick their day, their time, when they want to have it, where, and in the comfort of their own home, surrounded by family or whatever, their support system.
I never thought of it like that, but the way you just mentioned about patients who are on maintenance therapies and they're back at work, and if they do have to get their treatment and they might have to take extra time off. And I never thought of it in that way. I was thinking of it more as patients who are on current treatment within their treatment regimen, but that's a great way to think about what the difference is with this and how it's beneficial. How have home infusions evolved throughout your career?
Home infusions have come a long way since I started in this business. We started with antibiotics, 5-fluorouracil for the 46-hour pumps and hydration. It was a select few patients for short course therapies. But today, we give many drugs that traditionally are administered in outpatient clinics in the home setting. Some medication courses are taught to patients and caregivers to self-administer, where others are nurse-administered, such as Remicade, IVIG, the chemotherapies, and the biologics and immunotherapy.
I can honestly remember when I was in clinical practice that so many times patients were, depending on what it was that they were given, they had to be admitted to the hospital as an inpatient admission, or they were having it done in outpatient clinic. But just the variety of treatments that can now be given in the home is really astonishing.
Absolutely. When I started my career, most of the therapies we're giving now in the home were an inpatient admission, 3 or 4 days. Very inconvenient for everyone.
Can you talk about what some of the benefits are to both patients and institutions for having home infusions?
The benefits for the patient is the flexibility. Like I mentioned earlier, picking their day, their time. We have patients who start their infusions at 6 o'clock in the evening. We don't particularly like an 8-hour infusion starting at 6 p.m. because the nurse is in the home to almost midnight. But there are times that we do have to do it to accommodate our patients. Days of their week, it avoids their childcare issues, and of course, using up precious vacation time. The benefits to the clinics and the hospitals is the availability of chair or bay space for those emergent issues. Patient needs urgent hydration or a blood transfusion. We now have a spot for them. They don't have to come back another day or go to the emergency room. So it really does free up the clinics for those who are more acutely ill.
When you were talking about just that patients have the flexibility and they can make the decision on when those are, and that example that you had of starting something at 6 p.m., just the fact that the quality of life that a patient is now being able to have, that just adds to that quality of life that they have access to by having those infusions in the home and not having to go into the clinics.
Absolutely. And when you break it down, if someone gets 2 weeks vacation and they get a Remicade infusion every month or whatever, that's half their time or all their vacation time. So this really puts them back on a normal life path with their family and friends.
Can you tell us a little bit about the Penn Home Infusion Program and how it integrates with the Outpatient Cancer Center at Penn?
The Cancer Care at Home program has been working very closely with the clinics to safely transition eligible patients to the home setting. The goal is to improve the patient experience while maintaining safety and efficacy. Before the Cancer Care at Home program was launched, Penn Medicine at Home had already been providing care for Penn patients in the comfort of their home for more than 2 decades. This included some patients with cancer treatments like hydration and anti-nausea medicines, but we never tried to bring cancer treatments to the home and to this extent. The Cancer Care at Home team evaluated a list of cancer drugs that could be administered at home based on 4 factors: whether the drug was stable and safe to deliver at home, whether the target patient population could safely receive the drug at home, if their insurance would cover it, or if there were restrictions that they had to go to an outpatient or inpatient setting. And would it be economically sustainable for Penn Medicine to administer these drugs at home versus a hospital clinics? And the benefits we found to the patients and family included the ability to be treated when they wanted to, in stress-free, familiar environment. Family members or themselves did not have to take time off from work to drive to chemo visits. And literally, they could sit and hold the family pet while they were receiving their medications and just relax in their own space.
So the benefits for both the patient and the institution, just in those examples that you gave, are so huge. And just the safety that patients have and the comfort of their home versus being in the clinic and all of those things. It's just amazing. It sounds like such a great program that you guys have put together. So in February 2020, Penn established a program called Cancer Care at Home that expanded on the home infusion program to include additional treatments. Can you discuss how that came about and what the nursing role was in that process?
We've expanded the drug treatment protocols based on the growing demands for cancer treatments and the lack of chair or base space in the clinics. The nurses in the clinics actually helped identify patients that would benefit or be the best candidates for this program based on their response, how comfortable they thought they would be with this out of the secure environment of the clinics. So between physicians and nurses, the program was born to move them to the home.
With everything that you did on expanding that home infusion program, the timing couldn't have been better, I'm sure. With COVID-19 and everything, how has that grown in response to the pandemic?
I'm very grateful in hindsight that we had already planned to start this program, because with the coming of COVID-19, we scaled up very quickly to meet the demands created by the pandemic. From mid-March through late April, providers increased referrals to Penn Home Infusion Therapy from 39 to 310 patients, which is 700% increase in the number of patients participating in the program. We did this by leveraging learning from providing and administering other cancer therapies at home to rapidly expand and add new treatments at home for additional patient populations. Today, we have redirected hundreds of patient visits from our clinics and hospitals to patients' homes while maintaining timely, safe, and effective cancer treatments during the pandemic. Since the program began, patients have now been referred for 13 different cancer treatments at home. Working together across the health system with pharmacists, physicians, and other clinicians, the team has identified at least 13 additional cancer drugs that would be feasible and safe to administer in the home. The nursing staff has been educated, and our safe handling and administration guidelines have been updated to meet the standards of care. Along with this, patients leaving the clinics, we've brought some of the nurses from the clinics into the home care role to help care for these patients. So some of the patients are actually seeing the nurses that they saw in clinic in their home. They have also been a tremendous support to the home infusion staff that were already seeing patients in the home for years and to support these cancer patients and make the transition smoothly.
That's amazing, that increase in number. I can just imagine the sigh of relief almost, or that patients are now able to do that, and how they felt during this time in the pandemic about coming into the clinic or having to go out of their homes. And the fact that you already had this program in place was amazing.
It was very nice to be able to keep them safe and to limit their exposure to this disease that could have actually been detrimental to them.
So many other institutions are beginning to introduce home infusion programs to meet the patient needs during this pandemic. What are some of the factors that nurses building those programs should keep in mind?
What I consider the most important and basic piece to this whole program is communication. Communication with the providers, with the patients, with the pharmacies providing the drugs to coordinate the care. We are actually transitioning to the same platform of EMR as the main hospital uses so that the communication can be instantly real time and transparent.
One of the things that you talked about was how, as this program has grown, you've clearly had to add staff with just the volume that has grown to. And then you talked about transitioning some of your outpatient nurses to this role, the home infusion role. Can you just talk a little bit about how that actually works as far as the nurse? And you mentioned earlier, you don't like to start, you would hate to start a 8-hour infusion at 6 p.m. because the nurse would be there so long. Can you just talk through what an actual visit would be like for them?
As we geared up, obviously we needed additional staff. The clinics were lighter. It was a voluntary program asked by their managers who would like to continue to care for patients, learn the home infusion piece. We had at one point 10 nurses, what we called redeployed, that we brought out of the clinics. They were paired with seasoned home care nurses that also had been at one point clinic nurses or inpatient oncology nurses. They went out in the field. They taught them the home care. They assessed the program we were doing, made sure that we had all the pieces in place, but we trained them in the home so that we had the additional staff to do it. Our nurses, the redeployed nurses, these clinic nurses come in, they're working 12-hour shifts, 8 to 8:30. Our home infusion nurses either work 10 or 8 hours, and we have an evening staff that starts at either noon or 2 p.m., running to 10:30 at night to meet the needs of the patients. An average visit goes in, any other visit, clinic, whatever, we go in, we identify the patients, we do vital signs, doing a complete assessment, either start a peripheral line, access a port, if they have a PIC, use that, follow the physician's orders, hang fluids, pre-meds, sit with them for monitoring, a lot of talking, a lot of becoming family in these visits. When it's done, clean up, leave everything. The next day, someone from Penn Home Infusion comes, picks up the waste so it doesn't sit in the patient's home. And yes, we go back probably 2-3 days later, draw labs and do an assessment to see how they're doing. We have people on call overnight in case they have a problem after hours, just to give them that extra layer of support.
So the nurses actually stay in the home for that whole time during that infusion with the patient and the family.
Yes.
Great. What a wonderful way, like you said, just to have that, to build that rapport and that relationship with the family and to keep the continuity of the care and that trust that the patients had in their clinical staff when they would be going into the outpatient department to get those same kind of treatments, but now having that extra added safety of being in the home and the comfort of that. What advice do you have for nurses to ensure that those programs are successful?
The advice I have is to plan, pre-plan, work with the stakeholders, know what you need to do before you have to go do it. Communication, have your nurses trained. If need be, we send some of our nurses into the clinic to work with them to assure that they're comfortable administering chemotherapy. It truly was a group effort to do this, but we revamped programs, double checking the meds, hazardous drug protocols, so that everyone was safe, the patient, their family, and the nursing staff.
Speaking of the hazardous drugs and keeping patients and families safe, talk a little bit about the best practices, for home infusions and also things that need to be considered when you're talking about safe handling in the home and with families. You're now in a completely different environment. You mentioned pets before. There could be children in the home. So those kinds of things. Talk to us about that a little bit.
Absolutely, yes. So we do follow the safe handling guidelines. We teach them to the family. Medication is not delivered until right before the infusion, sometimes the same day, the night before. They're told how to store them, to keep them away from pets or whatever. We have the needle boxes, whatever they need. The nurse caps it before she leaves. Definitely all about the safety piece, talking about how to clean the home, double flushing the commode. When they're done, we do our double checks. The nurse calls into the office and talks to either an oncology nurse or a pharmacist, and they do a FaceTime visit to do the label double check and identifiers. They verify pumps are double checked before they even leave the office. RN sets it, pharmacist double checks. So we're doing multiple layers of double checks to ensure the safety of the patients. Our pumps are smart pumps so that they have the drug libraries in to help with the limits and safe administration.
There's a lot to consider. We're going from your very sterile, not completely sterile, but sterile hospital environment in a clinic into a home, and all of those things that you have to make sure that you remember and you have there to keep everyone safe. And especially when you're administering the chemotherapies and the different treatment therapies.
Yes, it's the things we take for granted in the suite or in the hospital are the things we have to consider in the home.
Exactly. So you just briefly mentioned about pumps, and some members on the ONS communities raised some questions about effectiveness of various pumps and equipment in the home setting. What are the types of pumps most commonly used during these home infusions, and what are the benefits that you could talk about with each of the different options?
Overall, the best pump to use is an ambulatory pump. Poles and pumps on IV poles are a hazard in the home overall. Not that they don't have their place or haven't had their place, but you've got throw rugs, you've got pets, you've got children. IV poles are now an added hazard to those pieces. We use ambulatory pumps that have drug libraries, lock levels so the patients or families cannot change settings, little pouches, fanny packs, so that they can wear them and walk around with them if they need to. We send extra batteries, but a battery life should last for an entire infusion if we know it's not going to. The nurse is there, of course, to change it. For a 96-hour 5FU infusion, we send an extra battery and we tell them on this day, at this time, we want you to pause the pump and change the battery and put it back on. And if need be, we have nurses sitting to do virtual visits with them to walk them through and make sure everything is the way it should be. So anything that can keep the patient safe without adding extra tripping hazards is what I recommend.
So we talked about keeping everyone safe. What are some possible complications when infusing in the home, and how can nurses help to mitigate that?
Possible complications, of course, is the obvious patient has reaction. We send anaphylaxis kits with anything that a nurse administers, and they have their freestanding orders from the physician what to do. In the home, 911 is your friend if it's that severe, but other reactions or side effects is all about the education to the patient. They wind up with extreme nausea, vomiting, or GI symptoms, to call into their provider. We can go back and hydrate them and the nausea medications in the home before they have to drive to a clinic and try to be seen and get it. We can do it quickly. A lot of them pre-order hydration if the patient needs it, and it's set up to go. Or we disconnect the chemo and they get hydration for 24 hours after at home. Family and the patient are taught to take it down. The nurse will come back and de-access the port if that's what it is. If it's a PICC line, they're taught to flush it. So it's all about preventing and keeping them home.
A lot of patient and family education too, just in listening to what you were saying, and how you really have to teach those family members things that they probably never thought they were going to have to do.
Absolutely. And we have pre-printed color schematics about flushing guidelines and stuff. So if they're unsure, they're taught to open it and look at it. If they still can't figure it out, we're a phone call away. But the instructions are literally in writing and pictures for them to be able to do it.
Yeah. Even with it being so much nicer for the patients to be in the home, I'm sure you really have to evaluate if those family members are willing and able to do that added work or those new jobs that they have to do in helping to care for their family member.
Yes, and that's part of the pre-assessment that the nurse in the clinic is doing and talking with them about. Is this something you're comfortable with? Is this going to be something you and your family will find beneficial, and be an active participant in your care of your loved one?
Yeah, another really important step, that's for sure. So we have another member from the ONS communities that wrote in who was curious about how nurses can secure port needles and tubing to ensure that it remains in place in the home. What advice would you have for this concern?
For decades, we have actually been sending patients home with the portable pumps with the 5FU. Occasionally mishaps, but it's all about coiling it so there's tension against it and you're not a direct pull, figuring out what's comfortable for the patient in the process. But I will say we have had mishaps. More cats like tubing than I care to count, but it's teaching the patients the safety of what to do if something happens, and then calling the home infusion nurse to come back and fix it.
That's good to know. And I guess you're evaluating if there are pets in the home whenever you're looking into this as well.
Yes, that is one of our screening questions.
Great. So what advice do you have for a nurse who would just be starting out in home infusion? She just got a brand new job in home infusion. What would you tell her?
My best advice is to listen to the one who has done it for a lot of years. Build on your knowledge base, because people don't just come into home infusion because they think it's going to be a easier job. But build on your knowledge base. Take what your preceptor has to offer, because when you're in the hospital or the clinic, you have your stuff and your space for your sterile field. In the home, you have a very tiny sterile field that you create while you're there. So learn the differences, because you're in a patient's home and you're not going to intrude and take over.
Thank you for that. You have given us a wealth of information, and just talking about the program that you guys have and how successful and how much you're doing with this. I just have a few questions to round us out and finish up our talk today. First of all, what are some common misconceptions about home infusion?
The biggest misconceptions we get across the board, other than the chemotherapy, is that a nurse is going to come every 6, 8, twice a day and administer the medication, go home and take care of everything. Physicians, for some reason, think that the nurse is at the patient's beck and call. We're going to come in and provide the education and teach the patients to administer these antibiotics or these fluids. So we're non-intrusive in their home, and they can live as much normal life as they can. It's sometimes harder to do a home infusion than a clinic or a hospital infusion because you have what's in the home to work with. I'd like to say we're perfect, but we're not. Sometimes you get in there and there's no IV tubing, and it's, do I have any in my bag? Do I have a colleague nearby who can run me some? Or do I have to wait for the DME to send the tubing that I need to give this infusion? So it's a lot of pre-planning and a lot of being prepared.
A lot of organization.
Yes, that is absolutely it. And time management.
Exactly. So my next question is, what is something about home infusion that's not often discussed, but you wish people knew more about?
Every patient I have ever been in the home to do home infusion for has been so appreciative that they could come home and be there to get well. That someone really would come in to teach them this or be there for them in their environment. Sometimes it's just nice to sit in someone's kitchen and talk to them. Pre-COVID, have a cup of tea or whatever, and it's like visiting with an aunt or an uncle or a grandfather, whatever. I used to have my favorites that I would look forward to their visits of what was there that time.
I can imagine that time that you get to spend is so valuable. I mean, because it's so uninterrupted versus when you're in the clinic or when you're in the inpatient unit, you have other patients you're taking care of and all kinds of other things. And just that ability to have that time and talk to them and just really get to know them and their family members, that's amazing.
Yes.
So my last question for you would be, what are some resources for oncology nurses wanting more information about home infusion, whether that's developing a program or getting into it themselves for a position?
What I like when I interview a nurse or bringing a nurse on is I always like to send them out in the field with one of our seasoned nurses to shadow, to see what it is. It's not for everyone. Absolutely not. That shadowing can be eye-opening. The other resources that I recommend highly are the ONS resources on hazardous drugs, what should be done, calling a program and talking to them, talking to the nurses and seeing if someone's doing it, they're going to willing to share the information of, what they had to do to get to where they're at. Use your networking.
That's really good advice. We are definitely going to put some of those resources in our episode note links. Do you have any final comments for us today?
They sound a little bit cheesy or funny, but love what you do. Be passionate about it. I could literally talk about oncology and sometimes have, to the extent that I've bored people. And the comment I've always gotten is, isn't it depressing? And I have never found oncology depressing. I have found it to be so rewarding that I could spend all day talking about it and where we've come from when I started in this, and people being admitted and vomiting for days. And now we're in the home and they're living full, active lives.
Tammy, thank you so much for joining me today and for sharing your passion for not only oncology, but for home infusion. We appreciate that.
Thank you, Stephanie. It was a pleasure to speak with you today.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.